I have AI in practice. We have an amazing panel, so I'm actually going to have them come out up on stage, and I'll introduce. So we have Dr. Alistair Erskine, who is the Chief Digital Health Officer of Partners Health. Ed Marks, my colleague and CIO of the Cleveland Clinic. Mark Probst, Chief Information Officer at Intermountain. Sarah Vaezi is the Chief of Digital Strategy at Providence. And Dr. Rich Zane is Chief Innovation Officer. So we're talking about AI, and we just had a tour de force about the vision of what AI can do and hopefully will do. But let's bring it down to what's really going on within your institutions, because I actually think there's a lot of hype, and then there's the practical application. So I'd love to start with you, Mark, just because you're right there. Tell us about what's going on at Intermountain in the application of AI and some concrete examples, I think, for the audience to kind of hear your strategy of the application.
So, first of all, I don't love the word AI as an artificial intelligence. I prefer maybe digital intelligence. I think there's nothing artificial about what these systems are able to do and what they're learning to do. In fact, I think my own intelligence is more artificial than actually the computer, because what I lack for in knowledge, I can make up for in creativity. So nice. It's a different thing. But at Intermountain Healthcare, we've been involved with using AI, I think, at a level for decision support for 30 years. It just hasn't been as complex and as intricate as it is today. But we got involved, so we've used best practice care as one of the foundations for Intermountain Healthcare. And it would take months, if not years, to create protocols in, whether we're dealing with acute respiratory distress syndrome or any other difficult problem. And we do all the spreadsheets and the flow charts, and we gather the data, and we do the analysis, and we come up with what would be best practice in a care protocol. We actually brought in one of the vendors of an artificial intelligence product, and we fed all the data that we were using into this system. And again, this was something that took us years to develop before. We ran the algorithm through the AI product. It not only replicated what took us years to do, it actually found 2 or 3 things that if we did better, it would actually provide better care. So that was one of the very early things we did with artificial intelligence. We've also been involved with imaging, and I think a lot of people are involved with imaging and starting to train those algorithms so that they can be better for our radiologists and provide solutions there. And then, of course, RPA, robots, that type of thing are pretty prevalent. So, and I guess the last thing I'd say is we've been involved with Stanford in working on computer vision, training the actual system to see. And that's been a slow process, but a really exciting process. And there are huge applications for that, whether it be in the rooms, monitoring patients, or whether it be in actually documenting as part of an algorithm for documenting a medical record. So those are some of the things.
Just a couple. Rich, in your experience as an innovation officer, I'm sure your phone blows up always with vendor promises and people wanting to access your health system and deploy the latest, greatest technology. How do you navigate, the signal to noise challenge of, what is really the special sauce and actually implementing it within your health system?
So that's a great point. I don't think I go 18 seconds without someone coming and saying, hey, let me give you my card. Can we have a meeting? Can I sell you something? So the difference between...
By the way, he'll be backstage if you guys want to sell him something. He loves it.
Yep, and I'm at the Cleveland Clinic. No.
Yes.
So what we try to do is be very pragmatic and ethnographic about exactly what it is that we're working on. And we work at the bedside helping providers make better decisions. And that's the type of partnership that we want to have. We think about our partners as ideally we want to be their customer because we need the product that we're developing together. And then we want to participate in the value creation that we create when we come together and build a product. The last thing that I want is anybody who thinks they have an out-of-the-box solution to come and tell me about the problem that they know I have and the solution they have for me. What I want is a partner who thinks differently than I do, but understands that the progress in medicine is really social and change management and cultural, and that doctors and providers behave differently without excuses. We just behave differently. And that's the type of partner that we need. I don't want an out-of-the-box solution for a problem you think I have. I want to work with you to solve the pragmatic ethnographic frontline problems that healthcare has, and that's the kind of partner we look for.
Sarah, Providence, very, very progressive in creating these ecosystems of both in-house software development and, obviously access to the West Coast entrepreneurial scene. Your approach on, applying AI and getting these companies similar to Rich?
Absolutely, and I would actually say it's not just limited to AI. It's any digital company that approaches us, any solution company. First, we ensure that they sort of line up with one of our strategic priorities from a digital standpoint. And it's a very practical and pragmatic point of view in that we don't just want to test a bunch of things and then not have them create some value for us. But if we identify a priority, then we go very systematically through a process of sort of the how of how are you going to solve this problem. And we do very extensive, very sort of methodical build, buy, partner analyses, always starting with companies that are out there or technologies that we may already own internally, but something that already exists, so that that technology, so that we can make, have some speed to market there. We don't want to always have to create from scratch, but we always look at companies, and they need to meet our requirements, not just from a feature and functionality standpoint, but also from a business model standpoint, from a customer experience standpoint, and this applies to AI companies as well as, frankly, any other digital company out there.
Great. Alistair, I'm going to do a little curveball just because why not? So 2 weeks ago, there was a really interesting article in the New York Times Magazine. They were talking about the MAX Air, right? This is the Boeing latest and greatest, and 2 tragic crashes. And there was points around airworthiness and what they called, I want to get this right, airworthiness of the actual captain. So the ability to understand and read all of the data independent of a computer. And there was concern that the AI, or the augmented flight control systems, had eroded that and thus kind of paralyzed the brain and resulting in the tragedy. Where do you see, what's the role of, the chief digital officer, CIO, strategy officer, innovation officer? What's the role in while we're pushing forward with AI, how do we do it with a degree of trepidation and ensure patient safety and, clinical safety? What's that fine line where, well, the computer told me to do it, or, I'm actually using my actual brain?
So a couple of things come to mind. First of all, I would say that we don't have a series of physicians who round around the hospital as consultants that provide help to a team as to how to interpret when is the appropriate moment to use an AI tool. Mm-hmm. The same way you may have an infectious disease doctor that's making recommendations about antibiotics. There isn't a set of doctors yet that are physicians that go out and say, I understand the bias, the dangers of this particular AI algorithm versus that one, and in this case, it seems to be a better fit for the patient. So I think in the future, that likely will be an area that the medical field will pivot to, of kind of fill in that gap that exists. At Partners Healthcare, one thing that we've done to be able to address what you're describing specifically is basically a virtual rapid response team for health safety. So the idea being that just the same way that somebody is becoming septic and their blood pressure is trending in the wrong direction, and maybe a primary team is busy doing other things, and somehow there needs to be an intervention, maybe even that AI picks up, that there be an escalation process that can be extremely quick when it comes to things that involve digital health, including AI, to be able to understand the complexity that sits behind it and be able to immediately address it, or be able to take the time and delay it. So I think that there are some safety issues that are going to emerge because we won't be able to always predict how this technology will impact patients and clinicians that use them, that are trying to drive that airplane, into the sky. But then there are ways we can mitigate them. And I think the other thing to think through is also there's applications of AI that can be, the way information comes to a radiologist can be very much first in, first out.
Yep.
And there are applications of AI that aren't as risky, where it resets and reorders the tests that are coming in, because the AI picks up the fact that a patient has a stroke and then puts that test at the top of the list of things for a radiologist to interpret. So there are applications that are going to be less risky, that even if the AI doesn't work perfectly, is still a human that's going to be able to kind of take it to the last mile. And then and those can be even more amenable to sort of more of the black box, Eisensphere, mathematical, dimensional space type of AI. But I think that the other types of applications that are more around decision support, we need to know what the decision tree actually is to be able to work our way back. I think that may be a different set of applications and requires a more robust set of safety services that go around it.
Great. We'll come back to the black box concept, because I really want to unpack that, because there's a whole conversation, FDA and other things about, do you want to know what's in the box or not? But Ed, how do you do change management when you're overseeing a large enterprise deployment of an EHR, core systems, and you need stability, uptime, scalability, and I'm knocking at your door with the latest, greatest whiz-bang thing? How do you balance, entropy and entrepreneurship?
Yeah, I call it tequilibrium. What's our tequilibrium between tradition and what we're trying to do with digital transformation? And it is a careful balance, because you have to have your eye on both. You have to be almost bipolar, or what some people call bimodal, in terms of addressing both at the same time. And I think one way that we've been successful with change management is we really have this team of team concepts. So it's never an IT thing. It's really led by our clinicians. And Will's been a great champion for us and other clinicians who help with that change management. There's nothing like a nurse speaking with a nurse. So we work very closely with our CNIO, for instance. There's nothing like a physician working with other physicians, with our CMIO and our other medical directors. And it's really this team of team concept that really helps us with the change management. The other thing that's awesome to have is support from the top. So you already heard our CEO speak. He's all about digital transformation, and that's really the key, is having like for like speaking to one another in a team of team concept, and a chief executive that is setting the vision and direction.
Great. I'm going to throw this one out to the panel, so feel free to jump on this. So we talk a lot about AI in the clinical applications, right? We've talked about personalized drug discovery, time to treat, sepsis. Are there other areas which you think may be even more sexy within healthcare delivery for AI? Ed?
Yeah, I'll take a stab, but I just feel a need to share one really quick clinical example, and I'll give you a non-clinical example, because your first question was really about what's the practical aspects. So I'll give you a really quick personal story. I dealt with an elevated PSA score for a long time, and physicians said, don't worry about it, it's no big deal. And then I found out that we had co-developed with some other organizations this augmented intelligence PSA capability. So I took the test, and immediately they knew with 85% accuracy that I probably had prostate cancer. So that afternoon I had a biopsy, sure enough. 45 days later, I was cured of cancer, and that's all because of augmented intelligence, what we call augmented intelligence. So I love the clinical application because it saves lives. The other things that we're doing is email, right? We're bombarded with email, so we're using augmented intelligence and machine learning for email. So if you're willing to take the time and mark those emails that are junk and you don't want to have, the system learns and reduces your emails. So I actually had several clinicians come up to me and say, thank you, because that was like a big deal, right, is managing the inbox. That's another example. One more really quick that we're pretty excited about is in the area of cybersecurity. So we're now able to triangulate based on what we see in social media feeds, based on where you last logged in and traveled to, perhaps you're part of a global organization. It triangulates all these things, what's happening around the world, and gives us artificial intelligence capabilities to where we know we can predict what may happen or what maybe a virus or some sort of outbreak. And so we can take proactive measures to make sure that your compute is safe and secure. So it's very, very interesting, the different applications that are non-clinical.
Great, so we heard clinical and cybersecurity. Other areas other than cybersecurity, clinical areas that you think are really kind of interesting?
So I'll give you an example, and I can't say that this is anything resembling sexy, but I'll do the best I can.
There you go.
I'll say it with a very deep voice. But we've been looking at how we can better utilize provider time.
That
so
is
on
very
a
sexy.
on a very individual level.
Great question from the audience. Said, well, when is AI going to help me decipher the bill? Right? So how do we actually not only make care safer and higher quality, but affordable and transparent? Thoughts on that nut, and can it be cracked?
Well, as soon as one of you can develop the algorithm to have it do that, because it's pretty complex.
All right.
We're actually doing a little bit of experimentation a little bit further up in the funnel around insurance card capture and recognition of the contents of your insurance card. Even that is a bit of an AI problem because every insurance card is slightly different and there's different logos, and some may say Primera and Blue Cross, and some may say Blue Cross and Providence Health Plan. And knowing how all of that maps is actually a very complicated, relatively difficult task that AI can potentially address. And for us, the way that we're looking at AI is to solve any of the 4 Ds: dull, difficult, dirty, or dangerous. And in this particular case, that's where we've started the applying the patient financial journey sort of at the top of the funnel. And then we're doing a lot of work within revenue cycle using our RPA to support that financial kind of streamlining as well.
So we did a price transparency tool where if you're one of our patients, you can go to our website or your portal and you can put in what you're going to have, whether it's a procedure or a visit, and it gives you the price of what it's going to be to you, not just what it's going to be to your insurance company. It's, as Sarah mentioned, it's hyper complicated for a lot of reasons, but we, the collective healthcare, have purposefully built a lot of very complicated things into revenue cycle because even though most of us are not for profit, there's still that profitability. But doctors, facilities are all very different, and we've done it for the facility. Now we need to do it for the providers.
So I want to talk about, go back to, Alistair was talking about the black box. And what are your thoughts on your obligation to understand the black box or just assume that it works? So imagine we have a sepsis model, right? That your body is clinically deteriorating, and we have the magical AI that can detect it. Do you have an obligation to understand how it works, where its actual data lineage? Do you trust it implicitly? What's that obligation and what's that balance? Thoughts?
Because patient lives are at stake, we have taken the point of view that AI that we use needs to be both explainable and understandable, and that we don't, at this stage, we're not comfortable with the black box mentality or the acceptance of something that is a black box for our work.
The AI or the clinical decision support or whatever we're going to call it helps us make better decisions, but does not make decisions for us. And I think that's an important point.
Yeah, I think the only thing I would add is I think we do have an ethical responsibility to understand the black box. We hear a lot about bias in the data, and if the source has bias in it, then we're only replicating that bias downstream. So we need to be very, very careful in how we approach this, and definitely have to understand what's in that black box.
Our chief nursing officer, she has a phrase which I love, it's a tool, it's not the rule. So, don't implicitly believe an alert pop up, but always, use your biggest gift, which is your brain and your, clinical experience. Thoughts?
Yeah. We're not so good at it without tools, right? So the rate of error is shocking. The way we prescribe is confounding, right? It's not based on a lot of data. So we can say that these AI tools have to be bulletproof, perfect, right? But the reality is that we're not right. So they help us make decisions, but we can't hold them to absolutely unequivocally being right every single time, because we're rarely right every single time.
That's great.
And they're just going to improve over time. I mean, right now, we're spending immense amount of times testing and looking at these AI products and looking at the data that's going in and the results and making sure they align with actual clinical knowledge. But over time, they're going to get better, just like the black box in the MAX aircraft is going to get better and prevent the kind of accidents that it's had. And I for one, I'm glad they have that box. I don't want the pilots not to know what to do. I think that's a different problem. But the fact that they have it is just incredibly comforting to me, as complex as these planes are. And then you look at the self-driving car and how long we've been testing that, and it still has problems. But it's going to get there. You know it's going to get there. And that's going to make things safer for all of us. So I'm bullish.
I love it. I want to talk a little bit about data, because companies coming in, what they really need and why they want your business cards isn't because they love you, it's because you have something that is a tremendous asset, which is data. Your thoughts of how your institution is approaching, it's a chicken or egg. You need to work with partners and collaborate because it's the right thing to do to improve patient care outcomes and affordability. But you also have a sacred obligation to protect and be stewards of patient data. How do you manage this? Because we struggled as well.
So, and it's, you bring up the point that AI in its application is really, less than 10% of the work, that most of the work is data management before you apply the AI, and most of the rest of the work is implementation, adoption, and impact after you've kind of come up with your AI. But on the data side, at least at Partners, we've taken a pretty conservative approach of, what we believe is highly and well annotated data, because once it gets released to the wild, you don't know what happens to it beyond there, or how it's going to be used and for what intent. So I think probably more on the side of conservative rather than progressive has been the approach that's been taken so far. And I think the other piece is that, it's no secret that a lot of the data that's being collected isn't necessarily, the way you would hope it to be. I mean, all you have to do is run your own AI and go through 100,000 rows of patient data and find out that you have patients that are taller than the Eiffel Tower or hotter than the center of the sun, and you need to, and that's because a decimal point was off or because something was collected. So in some ways, you have to throw away those data points. But there's a lot of that. So releasing the data is one thing, but releasing it in a way that actually is accurate, because maybe the selection box in the EMR was picking ARDS as a top thing, and suddenly you find out that a lot of patients are susceptible to adult respiratory distress syndrome, and it's only because it's the first thing that's being picked. So I think releasing the data, we take a conservative approach, but the data we release, we've got to make sure it's actually been, to some degree, managed so that it has the right information in it.
Yeah. Ed, your thoughts from a CIO perspective, and again, uptime, security, data provenance is your bailiwick, but folks like me are knocking the door with the shiny object and a wire looking for a plug. How do you describe the working relationship between companies who need access to build these models and advance the field, but us ensuring uptime, safety, reliability?
Yeah, it goes back to that tech equilibrium I was speaking about. It's not this or that, but it's this and that. And so we try to create very safe environments. So we definitely have a secure environment, but within the secure environment, we allow opportunity to innovate. I call it innovate at the edges. A really good example is we have a global community that started out of the Cleveland Clinic called BrainX. It's my favorite meeting of the month. It's after hours. It's all these clinicians, mostly physicians, who are awesome physicians during the day and programmers at night. And they're doing these amazing things with AI. And it's great because they can do it in a safe environment, and they've created these algorithms and these programs that are really impacting patient care in a positive way, in quality and safety. And so it's allowing for both. So creating that safe environment first and foremost, but within that environment, allowing for what I call sort of scrappy innovation at the edges. So it's a balance, equilibrium.
Great. Other feelings around this access control and I'm curious, governance around the data, and how do you, is it the role of the CIO, the digital officer, the CEO? What's your thoughts on how does an organization create and manage this important asset?
Yeah, and I would suggest we're just getting better at it. I wouldn't even say good at it. And it's all of us, right? I mean, we play a role around the provenance of the data, and is it secure, and what could we do with it? Can we put it in some secure area where they can use it to do their, work on their algorithms, but never take it from us? Or there's times when we actually have to share data. So I think the CIO plays a role. I think the CEO in protecting the overall organization and the reputation of the organization plays a role, and finance plays a role. Right? Yep. Are we giving them the data, or are we going to get something out of that if we provide intelligence into the process? So, I mean, it takes a village.
Yeah.
Our strategy is we built a data warehouse as a collaborative venture with the School of Medicine, all of our hospitals. And every evening, every discrete data element from our electronic medical record goes into this data warehouse, gets synthesized. Claims data goes in, genomics data goes in, and then we've built a layer of tools where we can have our partners mine those data with us. It never leaves our environment, but we can build together the AI or the algorithm.
Sarah, similar approach?
Similar approach, excuse me, and I would say for us, we've taken an approach that not just within our system, but between systems, so that the power of AI really is fully realized when there's massive amounts of data, and no individual system, especially for increasingly complex kinds of algorithms or use cases, can sort of do it, I think, on their own. And so we've also taken the approach to say, we want to work with other partners where we can all collectively transfer and transform our data into a secure place that we can then build on top of.
Awesome. We're coming up on time. I want to do a speed round. Something that just you saw and you're like, wow. Like, can you give an example of an AI application that you said, holy smokes, this is going to change. This is going to be profound impact. I can speak personally. When I saw AI renderings of DICOM images, so images of chest CTs and ability to actually manipulate in space and time, and now they're actually having the medical students train through that. That is unbelievable. I still have my formalin-soaked medical atlas. It stinks. But they now have access 24/7, and it's constantly learning and evolving. Are there other examples that you think, wow, this is unbelievable and gets you excited?
Well, I don't know if it's unbelievable, and I brought up the virtual triage earlier, but I've seen a product that it isn't just what's in the EMR, it isn't just what they can find out on social media or understand about your health apps or your wearables, but it actually sits in the cloud and it understands what you're doing with pharmacy and all the other aspects that manage health or need to be understood to manage health. Pretty cool stuff, and that's awesome. It's right there on the edge.
I think the coolest thing I've seen is an AI algorithm that looks at a leukemia patient's genome, compares them and their clinical outcomes to every other patient, and almost overnight, we've reduced by 22% the mortality for first chemotherapeutic exposure in leukemia, and that's literally awesome. In months instead of the 7 to 10 years that is usually a research cycle.
Yeah. Sarah, that's a
It's a hard one to follow.
That's a hard one to follow, but go for it.
I alluded to the virtual assistants for the providers. I think from a practical, the burnout problem that we have with providers, we've seen ambient listening virtual assistants that all but eliminate the need for providers to do charting outside of the visit. And when we've looked at the time that providers spend in the chart, it goes to 0 in after hours and is reduced by 30% in every hour throughout the day. So it's pretty incredible. I mean, they're still early, but I think that, to me, is just tremendous.
I'm going to applaud for that one. This is a dream. Alistair?
So I think people in the literature have talked about the difference between evidence-based medicine and practice-based evidence. And the idea that we sit on a mountain of data and sometimes we just don't know what to do. It could be a rare condition. It could be something that there isn't a randomized controlled trial for. In fact, most of the way we practice medicine is just that way, using whatever evidence we have and then using the rest to be able to figure out what to do with the patient. An application I think is going to be very powerful is an AI application that is identifying patients like mine to be able to figure out when there is an evidence that's obvious and easy to use, to be able to identify what happened to other patients when they went across different courses of treatment and what is the next best step for me to take as a result. And I think we're right at the edge of being able to do that. There are a significant number of privacy laws and other modernizations that need to occur for that to be able to go full swing. But we will sit on a mountain of data. Most of it is untapped and sits in clinical notes. And to be able to take that richness of the data and use it in real time to figure out what to do with your next patient, I think is a good application.
That's awesome. Ed, the last word.
Yeah, there's several good contemporary ones at the clinic, and it just amazes me when I hear about them and the impact on
Live. Go.
So one that has to do with radiation therapy, which traditionally you have a tumor and you provide the same amount of radiation across the whole tumor, and then you hope for the best outcome. And so our amazing clinicians and researchers developed the capability that it's using AI and machine learning that is much more focused now. And so the failure rate went from 25% to 5%. So that's a huge impact from a patient care perspective, not to mention the clinicians and everyone involved in the care of that patient. So that's one of those, it's like, wow, that's amazing.
Well, I want to thank the panelists. Basically, AI is real and it's here and it's exciting. And I couldn't be more appreciative of your time. And please give a warm hand.